you. So, yes, I'm John Rose. Most of you know me. Um, I did have the pleasure of working with Dolores for several years, and we stayed friends through the decades. Um, Dr. Gallagher Thompson is an internationally renowned expert in caregiving. She started researching family caregivers back in the 80s and has continued since. She has more publications. I think if I listed them all, it'd take up the whole 90 minutes. And she's still working on one. Um, she's received honorary degrees in foreign countries as well as in the United States. She's received the American Psychological Association's highest honor of being a fellow of APA. Also, I believe, a fellow of the Gerontological Society of America. Um,
I think that's enough, John. Thank
Well,
you.
I do want to mention that you have personal experience
Embarrassing.
taking care of your wonderful husband, Larry. Um, and I also have personal experience taking care of my parents and my wife's. And we have prepared a handout with resources that both those recommended by Dolores, some by me, some by Barbara, and some others. So yes, so take it away, Dolores.
Okay, well, I second what John and Susan have said. Welcome, everyone. And we're glad you're here. And I'm very glad to have this opportunity to share some of what I've learned, from my own experience as a caregiver and from my research, which has, as John said, spanned quite a bit of time. So could we have the next slide, please? So we'll just be going through. I have a number of slides. I think they were sent to most of you beforehand and a number of handouts. So we'll try to do most of them. I'll probably skip a few in the interest of time. But I did want to mention that a year or so ago, I published a book called Family Caregiver Distress, which is intended for providers who are working with family caregivers. So if any of you are in that role or know people, you might refer them to that book. It's a primer, so if people with no experience or limited experience can learn a lot. And I've done a great deal of work with various ethnic and racial groups. And then with my husband and with Barbara Summer, we've conducted a good deal of research and clinical care in treating later life depression. So next slide. I would like to have, before I go into the data, I'd like to take a moment, 1 minute, seriously, for each of you to say what your name. I can, even though I can see them, not everyone can see the screens of everyone else. So your name and who you're caring for, if you are a current caregiver, who you're caring for, and what do you hope to get from attending this evening. So let me start with the first person pops up on my screen is Sandra. Sandra Epstein, would you like to go first? We know you're Sandra, so who are you caring for if you're a caregiver, and what do you expect to or hope to get from tonight's talk? Sandra, you're on mute. Can you unmute her? Who is the gentleman that's running the slides? What is the name of the person running the slides? I forget his name.
Jake.
Jake. Okay, Jake, can you unmute Sandra? If not, let's go on then to give Sandra a minute to unmute. And how about Yesh and Debbie? Would you like to go next?
Sure. You'll notice on the screen Adam Steinharder. And I point that out because Adam's my nephew, and he's with my sister right now. And it's her husband who we're all caring for, and we're all caring for each other.
Mm-hmm. And what do you hope to get from attending this?
Any insight that will help. It's anyone who knows my brother-in-law knows he wasn't easy when he was well. So
I see.
it's a challenge. It's been a real challenge.
All right, good, thank you. Mimi, how about you next? You're the next one that pops up on my screen, so.
Hi, everyone. So I am a daughter with aging parents, and I'm also working on helping my mom with my dad, who has cognitive and physical decline. And so I just am always up for more information and and to be around others in similar circumstance.
Great, thank you. All right, Miriam?
Okay, so my husband's 80 and I'll be 80 next year. And I think we're both in this category, but we're at the beginning of this journey and I think both of us want to understand it. And he does have dementia in his family, so we're anticipating.
Okay, and it looks like Sandra is off mute now. So Sandra, would you like to share who you're caring for and what you hope to get from this evening?
Okay, I am caring for my husband. And this is a very new experience for me because our lives were spent with a lot of active intellectual activity. And now suddenly I need to kind of step back and think of it in a very different format. So I'd just like as much insight into this whole area as I can get.
All right, okay, and Barbara, you popped up next, so
Well, I'm just so thrilled that you're here, Dolores. And like John, I've known you for a really long time. I was telling Dolores, I remember nursing my son, who was then 3 months old, who's now 38, when I was participating in a research project, and we were at Larry and Dolores's home, and it's been a mutual admiration society ever since. I have the utmost respect for Dolores, and I've seen in the patients that we have treated together how dramatic the changes have been in their lives because of the work that you do. So it's not just that you're a researcher; it's also that you're a person and a clinician, and that is just a wonderful combination. So sadly, I am not the caregiver. Both my parents have died, and both of Alan's parents have died as well. So this is really here just to, see how it's going in the area that I retired from.
yeah, Barbara and I are still colleagues at Stanford, so thanks, Barbara, for joining. And next is Marilyn.
Okay. My brother has a history of bipolar disorder and has been his mental health has been a problem since he was 16, and he's now 77 years old. And about 7 years ago, he had a kidney transplant because when he had bipolar disorder, they didn't monitor his medications, and he had kidney failure as a result. And but anyway, the last 6 years or so, his wife was alive, and she was having a lot of trouble managing him. And about 6 years ago, she placed him in a nursing home, and so I had become very involved with their problems and their issues. And she passed away about a year and a half ago. And at that point, his son became involved because his it was a second marriage. His wife really didn't want anything to do with his son, but his son has become more involved, and we have partnered together, and we've moved my brother from Pennsylvania to Connecticut. So I'm involved with his care, and tomorrow I have a meeting to transfer his guardianship from Pennsylvania to Connecticut.
Okay, well, it sounds like you've got your hands full, so thank you for sharing that. Nancy, you're next up.
Hi, I'm taking care of my husband, Bob, who's in the sort of medium early stages of Alzheimer's. He had a traumatic brain injury 6 years ago, which he recovered from mostly, and then was stable, and then has started deteriorating and has been diagnosed with Alzheimer's. So I'm just interested in other people's experiences and how to cope and manage everything going forward.
Okay. All right, thank you. I see Sandy. Yeah, Sandy Blaster.
Oh, hi. Yeah, hi.
Flaster?
Yeah, I'm Sandy Flaster, and my mother-in-law is also on, Rita Politi. So, and my husband is on with her. My father-in-law suffers from Alzheimer's. So,
Okay.
so they're in New York right now, but they thought they would, came on to join. They're night owls. So, but
Okay,
but they
great.
could tell you more about his situation. So when you get to Rita.
Okay, so Rita, would you like to go next?
Okay, hi Sandy, hi everyone. Yes, my husband has late stage Alzheimer's now, and any information that I can get to make his plight easier, my plight easier, I'm very grateful for.
Okay, thank you. And it looks like we have maybe a few more people. Adam Steinharter.
Yeah, so I'm here with my mom as the Asian, and Debbie had mentioned we're here to learn more about my dad and how we can support him.
Okay. And I forget already, does he have a dementia situation?
He does, yes. And
Okay.
so we recently have helped him into assisted living and working through that.
Okay, all right. Thank you. And Dan Epstein?
This is Jessica.
Jessica.
My mother has having memory loss issues. My stepfather is her primary caregiver, but we try to learn some things to support them.
Okay. All right. And last but not least, the last one I see is iPhone. There's no name associated with it, so I don't know who that is. iPhone 650 starts 787. Is there a person there? Susan, do you think there's someone there? I mean, do you have such a person on your list?
I do not have people's phone numbers on the list, but there are a number of people who have not, who signed up, who have not signed in as a
Yeah.
participant.
Okay.
So maybe.
Well, I think we'll move on then, because it's
Okay,
not clear
sure.
that there's anybody that's engaged in, that's listening on that number. Okay. All right. Well, thank you all for sharing, and I hope you will go away with some practical tips for yourself, because the purpose of this talk is to help you in the caregiving role. So it's not to manage the individual differently or better, or take care of other practical problems that you might have, but the purpose of it is to help you to develop some skills that will enable you to be as good a caregiver as you can, while at the same time taking care of your own physical and mental health. So the data I'll show you in the next few slides is from a report that was issued by AARP, which I'm sure most of you are familiar with AARP, and the National Alliance for Caregiving. It just came out in July, and they had over 6,000 people respond to their survey, so it is considered a nationally representative survey. And we do see that roughly 2/3 of caregivers are women, and about 1/3 or so, a little more than that, are men. And this is a bit of a change in the recent past, because it used to be that it was a higher percentage of women. So we are seeing more men take on caregiving responsibilities, and that they might have some other issues or unique issues to deal with compared to women. So next slide. This one, I want to point out that the relationship between the age of the caregiver and the age of the care recipient. So the care recipient's age is on the left and the caregiver age is across the top. So if you look at the first line, you see that over 60% of caregivers of parents are over the age of 50. Way over 60%. And then when you drop down to the third line, you see that if you add a couple of them together, you see that about 75% of spouses are the ones who are who are taking care of a spouse over the age of 65. So we have two large groups. We have the children who take care of parents or parents-in-law, and then we have spouses. And because of the age difference and the difference in roles and responsibilities, they tend to have different problems, though some things shared are in common. On the next slide, we see about the prevalence of caregiving among people with memory loss. So about 1 in 5 people who have a dementia diagnosis I'm sorry, 4 out of 5 people get their care at home, which means that in this country, caregivers are the backbone of long-term care. If we didn't have family caregivers doing all that they do, I don't know what would happen to people in our society who need this care. The next slide, please. However, this care takes its toll on most caregivers. There is no caregiver I have ever met who has not reported at least some degree of distress relating to their situation. So many frame it in terms of the word stress, which is a general term that can certainly apply to many situations in everyday life. So sometimes in our studies, we tend to get more specific. So we ask about depression, we ask about anxiety, feelings of guilt, frustration, sense of loss and grief. So there are many emotions that caregivers experience, and some of them can be difficult to manage. So that's part of what we'll be talking about tonight. Recent studies have also pointed to the importance of loneliness, how prevalent that is, and the sense of social isolation that many caregivers feel, because they really do spend less time with friends. They have to, because they don't have enough hours in the day, and they do fewer things for themselves. So gradually their social world shrinks. So caregiving is not for the faint of heart, I like to say. The next slide, we show a conceptual model that is complex, but this is a smart group. So I'm going to take a moment to go through a couple of the main points here. This model has been around for 40 years, about that. 30 years anyway, 35. And what's important is that we're looking at the whole context. When we try to help a caregiver, we try to look at their background, the context in which they live, their socioeconomic status, their culture. Very important in terms of understanding the caregiver. We talk about primary stressors. That means what are you really dealing with? We'll talk more about that. Secondary role stress would be the additional things that you have to take care of. Many of the middle-aged caregivers who are caring for a parent or parent-in-law are also employed. And we find from the national surveys that employment suffers frequently as a result of these dual roles because of the responsibilities involved in those roles. As well, they often have children or teenagers that need to be taken care of. For those who are spouse caregivers, who are the older group that I mentioned a moment ago, you see this incredible constriction of the social life, and you see that there may be less availability of additional caregivers to help them than they thought, and that is a secondary stressor. There's also the mediator. So let me call your attention to that section. And what that means is that the impact of the primary and secondary stressors on the caregiver can be affected or mediated by a number of key factors. So two people in the same situation, objectively the same primary stressors, may react very differently depending upon these mediators, these individual factors that are so important in building our sense of confidence that we can continue as caregivers. So I listed a few of the key ones there that were in the Perlin model: coping skills, the social network, one's sense of efficacy, and then the cultural values, religion, and spirituality. And we'll see this play out when we come more to the recommendations. So let's go on. These next ones, the next couple of slides, reflect on, again, data from the National Survey. What is it that caregivers do? You know, when we say caregiver, we usually mean a certain range of activities. In the early stages of Alzheimer's or other forms of dementia, the most frequent thing is help with the activities of daily living. And those are listed here. The common ones, the most frequent help is with grocery shopping, transportation, housework, preparing meals, managing finances, giving medications. Once those things start to happen, then even if you hadn't considered yourself a caregiver before, now's the time when you're going to start thinking, I must be a caregiver because look at what I'm doing, which is over and above what you're doing in your normal life. Excuse me a second. Alexa is giving me a timer. Alexa, off. Excuse me. Thank you. Okay. The next one, next slide, deals with the more personal. We call them the ADLs, or the activities of daily living. And one of the main ones is incontinence. Incontinence is common. Feeding, bathing problems, getting dressed, getting in and out of bed. These are much more personal care, hands-on issues. And for many of these, caregivers hire additional help because they're so stressful to try and do all of that yourself. Now, on the next slide, we see some other things that caregivers do. Okay. We talked about IADLs and ADLs and help with managing medications, but treatment compliance. So many people who have Alzheimer's or other forms of dementia also have medical problems. These often coexist, right? So diabetes is a good example of a common medical problem that affects many older adults, but it can affect middle age as well. And that requires a certain treatment regimen in and of itself, in terms of diet, exercise, things that you need to do, checking the sugar, making adjustments, and so forth. So when you have a person with dementia, especially as they progress through the stages of dementia, they have difficulty complying with those medical regimens that would keep them in overall good health. So caregivers find themselves taking on more medical tasks, as well as the other activities that they need to do that go along more with the dementia. Managing behavioral problems. This happens more in the middle stages, when the dementia has progressed and the person is not able to manage their behavior. So we call it emotional dysregulation. It's one example of it, where the emotions just come to the surface people say things or do things that are in a very uninhibited way. And that can be a problem and often is for the family. And you can see sometimes dealing with the family itself is its own problem and stress, because not all family members agree, as I'm sure many of you know from experience. They don't agree as to what the care should consist of, who's going to do it, who's going to pay for it. So negotiating the family conflicts is another aspect of caregiving that makes it stressful. If we go to the next slide, some caregivers, especially of dementia people, do even more. They modify the home. They put in assistive devices. They advocate for their patient because the person can't really speak up for themselves, make their wishes or their needs known very well. Family member becomes an advocate. And I mentioned about the difficult and burdensome behaviors. The Alzheimer's Association is a great source of information about how to manage some of these difficult behaviors. That's the subject of a whole nother hour and a half at least. So I'm not going to go into detail on this now, but in your list of resources that Susan compiled, you will see the website for the Alzheimer's and other groups that are well resourced and that you can trust. They are trusted sources of information, so you can find out a lot more about managing specific difficult behaviors. And then the last in this section, and then I'm going to ask you to communicate a bit, has to do, if I could have the next slide, it has to do with the stages. Okay, so some of you may already be familiar with this, some of you may not. It is in the slide deck, so you will have it to look at. And I think it's useful to help you know where in the process, where in this continuum is your loved one. And you can certainly ask the physician for that information, and it will help you understand what's happening to them. It will also help you to make sense of what it is that you're doing. Because the more they progress through the continuum, from the mild to the moderate to the severe, the more you will be doing for them. The more varied things you'll be doing, and the more demanding they will be. So it's very helpful to know this information. And I'm going to stop here for a moment and ask if at least a few of you would be willing to share. What is it that you do now for your loved one? How, in what ways, concrete ways, are you functioning as a caregiver? And don't all talk at once. You could raise your hand, you could take yourself off mute, or if you want, I'll ask specific people, but it would be nice if people would volunteer. So what is it that you're doing now that helps you to know, yeah, I'm a caregiver, what are these activities that you do? Looks like Marilyn came off mute. So Marilyn, did you want to say something?
Well, my brother is in a locked facility, a nursing home in Connecticut. And he, right now I'm making decisions for his care as his guardian, and I'm managing his money. And I made decisions about where he will be buried, and those kind of things. He's
Yeah. So
he has
yeah. So allow me to comment, if you will, Marilyn.
okay, sure.
It sounds like you have, he would be in the moderately severe or more severe stage. And what she brought up a good point that wasn't on the previous slides, which is decision making and end of life preparation. Those also go with these later stages where the individual really can't make their own decisions anymore. It would be dangerous if you allowed them to. So she mentioned the word conservatorship earlier as well. So that is a legal term for how someone can be given the authority to make these kinds of decisions when the individual in question no longer has the cognitive ability to do so. So these go with the later stages. Now, is there anyone here? I thought I heard a couple of people say they were more in the early stages, working with or family members in the early stages. So would anyone care to comment on the other end of the continuum? I think it was, yeah, Miriam.
Well, being in the early stage, I just remember Richard's mother was so, how can I say it, interpersonally, not sophisticated, but adept that many of us didn't know. Actually, his aunt didn't know. So my question is, because we're so close to each other, I want to make sure I know when he shouldn't be driving anymore or picking up the grandkids or that sort of thing.
Yeah. Yeah, that's a great question, and it's a difficult one to answer because it's very individual. And it is something that the physician, whoever is the primary care doctor, or if he has a neurologist, then those individuals would be the ones to consult. There's no hard and fast rule that says that just because you have a diagnosis that you cannot drive. There is no such rule. It is recommended that if a diagnosis is made, that the physicians must inform. Let me correct the way I said that. The physicians must inform the DMV. That is their job, to inform the DMV once a diagnosis has been made. But whether the license is revoked or not is not automatic. And it looks like Barbara might want to say something about that.
Oh, yeah, it's worse than that. At least in California, the doctor can lose their license if they don't report it. And it's particularly problematic because we're in an area that has such poor public transportation. But nonetheless, Dolores, you're quite right. It has to be reported, and it's sometimes it risks breaking off relationships with patients. They get really angry and they leave treatment. But our hands are tied. Sometimes what I have done is if somebody's on the cusp and I'm not sure, I demand that they go to an adult driving school and get a letter from that person from the school stating that the driving is okay. And I threaten the patient, if I don't have that letter in my hands, then then they're going to be, DMV is going to be called. And that has actually been very helpful because it has spared people having to relinquish their license when it's not ready yet. So it's a huge problem.
Yeah, thank you, Barbara, for clarifying that. So it is up to the DMV to either issue or suspend the license. It's not up to the doctor, it's not up to you. The person, of course, can voluntarily decide not to. John, you want to add to this?
Yeah,
Go
the
ahead.
Hartford insurance company called the Hartford. It's a really nice free booklet that you can download online for family members in how to assess whether your loved one is safe as a driver and how to talk to them about it.
Yeah, that's a great resource. Thank you for sharing that. Yeah, and it's one of those difficult conversations, that's for sure, because most people who have a license do not want to give it up, irregardless of who says what. They feel they are still competent. So it's one of the most difficult situations to deal with. Nancy, you have your hand up.
Yeah, so I went through this recently with my husband where he had been seeing a neurologist and his cognitive scores were declining, but not to the point where the doctor would be required to report. But she recommended that he go to the Stanford Driving Simulation School and be evaluated, which he had done after he had his TBI and his traumatic brain injury, and at that point got good scores. This time he totally failed. But then he's just making the argument that, well, that doesn't have anything to do with actually driving on the road, even though they did a huge battery of different kinds of tests, not just a simulated driving thing, which anyway. And then he also had an on-road driving instructor who actually said he did okay. But the doctor at this point then filled out the DMV form and sent in all his medical records to the DMV. And I sort of was expecting that they would retest him or do something, but basically they sent back that his license was revoked just based on the
on the
medical stuff that
information.
they were sent. And of course he was just totally didn't get it at all. He didn't understand. He said he's had perfect driving and, you know,
Yep.
didn't see why this was happening, but it was very difficult.
Yeah.
I mean, it's a total loss of his independence, right? So that was hard.
Yeah, as John mentioned, that their downloadable resource from Hartford, and AARP also offers driving. Oh, John, there's a request. Could you post the resource on the chat, please, while we're talking? The AARP also has useful information on driving over the age of 50, I think. But yeah, and this is one of those things where sometimes the caregiver makes the decision and does things that you wouldn't normally do, but you have to if you think it's really serious and it's not being dealt with by the physicians, or the DMV doesn't respond in the way that you're hoping they will. Then a lot of times what families do is they hide the keys. You know, they literally hide the keys. They disarm, disable in some way the car. You know, they make other arrangements for transportation, so the car isn't a constant source of constantly in the person's presence. So there are ways you can deal with it, but I do want to move on. One last comment, Nancy, and then we'll move
Yeah,
on.
I just wanted to say that something that really motivated me was that I was told that if there's an actual medical diagnosis of dementia or Alzheimer's or something like that, if the person gets involved in an accident, even if it's not their fault, they can be sued for everything that you have because there's a medical indication about potentially not being suitable for driving. So that was just really scary for me and motivated me to get things done.
Yeah. Yeah, good. Thank you for sharing. Yeah. All right. So as you can see, each of you are in different stages and dealing with different issues. But yet you can hear the stress that's common throughout as people are talking, that sense of not sure what to do, uncertain, would like things to be different, wishing they were the way they used to be, and so forth. So let's go to the next slide. When the next couple talk about these all too common negative effects of caregiving. So I mentioned before about stress. I didn't mention about burden. So burden is that's a subjective thing. Some people, or two people, three people could be in the same situation, and one feels very burdened having to deal with that situation. And another one kind of rolls with the punches and says, well, I've dealt with difficult things before. I'll manage this one too. So burden is very subjective, but it's a term that used a lot in the publications that you might run into on the websites and so forth. So it's a good term for you to know about and think how it applies to you. Increased depression. In some studies, as many as 50%, 1 out of 2 caregivers were seriously depressed and weren't getting any help for it. They were just kind of, living with it, just being really feeling like their needs were not as important as the needs of their care recipient. So the care recipient came first. And that's an issue we see with many caregivers, that they really don't assess their own mental health and their own needs. Anxiety and depression frequently go together, and anxiety, especially about the future. What's going to happen next? Is it just going to be getting worse all the time? So too much worry about the future is very unproductive, as I'm sure most of you know, but it does seem to come with the territory. We have to learn how to deal with that. I talked about social isolation and loneliness. Health problems. Well, the health problems of the caregiver seem related to not doing enough self-care. So many of the caregivers I've worked with, they don't go for their annual testing, their mammogram if they're a woman, or other tests for men. They don't monitor their blood pressure. They miss their own medications because they're trying to keep the other person's medications on track. It's very clear that increased fatigue, sleep problems are very, very common. Most caregivers report that they cannot sleep adequately during the night, especially as the dementia progresses. So why is this important? Because even though the caregiver may feel okay at the time, if you don't deal with some of this, you will likely have problems downstream. And that's, so in other words, 5 or 10 years from now. So you want to be paying attention, be more observant of yourself. On the next slide, it's sort of a summary of the common caregiver stressors. This is from a separate report from the University of Michigan. The data pretty much agree with the national survey that I presented, which is that, roughly a third report fatigue, another third balancing work and other responsibilities, lack of time, balancing time with family and friends. So it's hard. However, next slide. We don't want to focus only on the negative. Okay, there are positive aspects to caregiving, and I'll bet each of you knows about that. You think about it, you probably experience it every day, and it's part of what keeps you going. That that it's important for you to keep doing this, even though it's hard. That that you may, through the process of caregiving, become more aware of your own needs. I was just saying that a moment ago. Your mental health needs and your need for your own physical self-care. Many caregivers feel appreciated. Now, not all, because again, in more advanced stages of dementia, the person really can't express that. But in the earlier stages, they often can, or other family members might express it. It can give you a sense of purpose, reason to get up in the morning, a reason to keep a schedule, a reason to keep things going as smoothly as you can in the household. And growing closer, only a third report that they grow closer to family and friends. The majority report distance. So that's a double-edged sword, that one. But in general, there are many positive aspects. You can probably think of others as you're reflecting on it right now. And we need to balance the positive with the negative. That may seem obvious to say it, but it's not so obvious how to do it, and how to do it day to day in your everyday life. Next slide. If we don't do it, if we don't take seriously the need to deal with our own mental health, our own stress, and our own health issues, then stress turns into burnout. Burnout is not good for anybody. Not good for you. It's not good for your loved one. Significant mental health issues. Okay, so like I mentioned a moment ago, if you're significantly depressed, very depressed, there's help for you, and that getting that help will make you a better caregiver in the long run. You want to avoid these chronic health issues. a number of studies have shown that caregivers have compromised immune systems. So what does that mean? It means you're run down. It means you get every flu or cold or whatever that comes around because your immune system is weakened from the chronic stress. And the rest of it you can see. The one I haven't mentioned so far was many caregivers develop their own problems with concentration and memory. Why? Because their brain is kind of overloaded with all that they have to do, and stress interferes. Stress interferes with cognitive processing. So if you're stressed and you're not dealing with it very well or reducing it or getting it to a manageable level, you're likely to show some of the same cognitive symptoms, not to the same degree, of course, but memory, concentration, problem-solving issues. So this is all to help to get you folks motivated to take care of yourselves, okay? Maybe I'm preaching to the choir, I don't know, but I hope that we'll give you some ideas for how to do that in the next 20 minutes or so. So the next slide, this one is from my book that I mentioned, Family Caregiver Distress. This stepped approach, what that means is that not all caregivers experience all the things I talked about, right? You have a different ratio, you might say. Some depression, anxiety, others guilt is more prevalent, others it's feelings of loss for the future, for others it might be just fatigue. So according to what you're experiencing, that will help you decide what level of care you need. What level of intervention is going to be helpful to you. So the basic building block, level 1, is education in self-care, and education, of course, about the disease, whatever it is, or however many you're dealing with in your loved one, learning as much as you can. The next level is community and family support. So things like a support group, attending a support group. Maybe you hire a care manager to help you navigate the system. And maybe you have an insurance consultant to help you with the ins and outs of Medicare versus Medicare Advantage and so forth. And maybe you have long-term care insurance. So you start tapping into that because you want to bring care into the home. The next level would be when you're experiencing enough distress that you're willing to sign up for a program of some sort and commit to it. So we call them psychoeducational because these are programs that combine elements of therapy with elements of education and with socialization. And they're offered in different locations in various communities. They're not universally available, shall we say, but there are programs online as well as in person. Well, used to be in person, they're online now, that offer this type of information in a group supportive atmosphere. And then finally, if what you're experiencing is interfering with your daily life, you are getting very fatigued, you're having chronic sleep problems, you really are run down and feeling that burnout, then you need professional help. And that's where therapists come in. There are many different kinds of therapists and therapy, which I'll talk about a little as we go on. And that is available to you as well. So if you think about your needs and you think about where you are on the pyramid, what level of intervention is going to be helpful to you, then I think you will have gotten something out of this presentation. All right, next slide. So this is my opinion, as a caregiver, as a psychologist, as someone who's worked in the field a long time. What's basic for successful caregiver programs? These elements, okay? I don't know how to draw a nice pie chart, so I can't make it prettier than this, but the information is there. Build your network, okay? And that is a task that most of us do not spend the time to do. We don't think about who's really there to help. Who can I call on? Really, who can I call on? What will they say? Are they available to listen to me? there's different kinds of support that we can have in our network. One kind is emotional support. You have someone you can really share your feelings with, your frustration, your sadness, your grief. They don't do anything. They listen to you. Maybe you have coffee with them or lunch or something, or you talk on the phone or you have a Zoom, and they listen and they offer you that emotional support. Other people can give you practical support, help you take care of some of those tasks that we looked at earlier, help you with the medication management, help you with getting the person to and from appointments, help you with figuring out insurance issues. Those are different people usually. They may or may not be providers, not necessarily family. And family often doesn't step up to the plate. So often we have friends that do. So you need to think broadly about your network. And I recommend this highly to every one of you. Next is learning adaptive coping skills. That's what the psychoeducational programs teach. Problem solving, reframing negative thinking, developing more positive routines in your day. The third is savor the moment, okay? Every person who's dealing with someone with memory loss or some form of dementia, they have good times and they have bad times. They have good days or good hours or good moments. If we only focus on what they can't do, what they don't do, how all the burden that we feel, we miss those. We don't see the joy that still can be there in the relationship. So I call this savoring the moment, pausing and paying attention and enjoying what's there. And the last is build resilience. Okay, and a lot of the next part of what I'm going to talk about is how do we do that? How do we build resilience? These others maybe are fairly evident, but building resilience is not quite so clear. So the next slide is just, this is a pie chart that somebody else drew for me, which you have, I think you have in your handout. And this is just another way of looking at it, the various dimensions of self-care. So it's a big term. It's an umbrella term for all of these things. And we need all of them in our lives. Now, this person isn't the best pie chart creator in the world either. So he didn't make them equal. He wasn't sure if the segments were supposed to be equal or not equal. So it's not perfect. We're not, we're not weighing in on that. We're just saying these are the dimensions. And if you look at it, you might think of some others that are important to you for your self-care. So it's food for thought. And it might be something to print out and stick on your refrigerator and see how you're doing in these different dimensions periodically. So next slide is why do we bother to manage stress and increase resilience? Can I have the next slide, please? Jake, are you there? Ah, there you are. Thank you, Jake. Okay, so we can flip all the negative things that I talked about, right? If we build resilience and manage our stress better, we're going to have better memory. We're going to have better quality of our own life, better sleep, and so forth, and more periods of enjoyment with our loved ones. So I hope I've sold you on it. So next is, what is resilience? So I put up the kind of the psychology definition of resilience, the ability to face adversity and challenges in ways that are at least partially successful, and the ability to move on and continue your life after the challenges are resolved or you have come to terms. So another way of saying that would be acceptance, right? There's a large component of acceptance in all of this that underlies the resilience piece. Now, there's a couple of blank spaces there because I'd like to ask you, any of you that would like to comment at this point, what do you think resilience is? How do you feel that you're manifesting it in your life? what do you think is important about resilience? How are you doing it? Can we have a volunteer or two to talk about resilience? I don't know, John would, or Susan, would you guys like to start us off? What goes through your mind when you think about resilience? What might be some other component of resilience?
Susan and I started yoga.
Hmm. Okay.
It's been very
How does that have to, what does that have to do with resilience?
the mind-body connection. So yoga involves both physical exercise to help improve our health,
Mhm.
but also relaxation and a sense of community.
Yeah, exactly. Exactly. So part of resilience is being able to try new things. Okay, Sandra, it looks like you wanted to say something. No, okay, no. Yesh and Debbie, did you have your hand up? No, okay. Miriam, yeah,
Well,
can't see all the names. So, sorry.
For some reason, when you said resilience, the word denial popped up into my mind. And it's like, with me at least, maybe it's a theme in my life, denial, not acknowledging the reality of what's going on.
Mhm.
So for me, to be resilient is to back up before you resolve or accept or face. You have to acknowledge whatever the challenge is.
Exactly. Well said. Very well said. Thank you, Miriam. I think most of us as caregivers experience denial. And, it does take some, talking to ourselves, you might say, and, being willing to experience some of the anxiety that comes with facing reality. It's not pleasant. We're talking about facing realities that are not pleasant, like if you get a cancer diagnosis, well, you can't get treatment or, mobilize your resources unless you are willing to accept and not deny that you have that diagnosis. And it's similar here. Susan, you wanted to add?
Yeah, I just wanted to say one of the things that helped me with my own father was to manage my own expectations of what our interactions would be like in the limited time that he had left. And so that helped me to be more accepting by managing what it was I actually expected from him in our interactions.
Yeah, and probably that was quite different than what you had expected or experienced with him in the past before
Yes.
the diagnosis. Yeah,
Yes.
yeah, a good point. Thank you. All right, well, let's move on. There are 3 key ways to build resilience, okay? And I'm going to talk about these: forgiveness, gratitude, and acts of kindness. Those are the 3 pathways or the building blocks to resilience. Those are the key ones. There are others, but we'll start with those. So next slide, forgiveness. Okay. There's a psychologist named Fred Luskin wrote a book about forgiveness. Many others have been written since then. Forgiveness is a tradition it's part of many religious traditions, as well as part of positive psychology. And there are steps to forgiveness. You can find all this online, or again, if you print out the slides, you'll see what the steps are. But I think one of the most important things is that it's for you. The reason you forgive other people and the things that they've done, or the slights, or however they've hurt you, is not for them or not because you're trying to necessarily reconcile with them. It's to reduce the burden on you. It adds to psychological stress to bear a grudge, bear grudges, to carry these things with us. It can eat us up inside. So the practice of forgiveness is part of letting go, it's part of acceptance, and it's part of what will make you stronger, which is Another way of saying resilience. Now let's go to gratitude, the next one. So we talk about the attitude of gratitude. If you can create an attitude of gratitude so mentally that you would like to be a person who is more grateful than ungrateful. You'd like to be a person who can see gratitude in everyday life. That's your attitude. That's mental. You have to start there. And then we start thinking about little things that we're grateful for. So I had a friend who had immigrated from another country. And when she came to our house one time to visit, she looked at our kitchen and she marveled at the things in the kitchen. Okay, the stove, the refrigerator, the dishwasher, because in her country and where she came from, they didn't have these things. They had small, little refrigerators and stoves and whatnot. They didn't have dishwashers. So she said, do you ever take time to just look around and be grateful for what you have in your own home? And that was a wake-up call for me, because no, I hadn't. But I did. After that, I started noticing, the flowers that grow in the garden. Some of them are completely unattended. I have paid no mind, but they grow anyway. In your everyday life, there are things like that. So noticing, cultivating the attitude, and then noticing, and then letting yourself feel good. Most people who feel a moment of gratitude also feel a moment of uplift. Their mood is a little bit better than it was before. So this is just an easy thing to do. Easy thing to do. Where it pertains to caregiving and can be a little bit more difficult, but very helpful, is what are you grateful for about that person? The person that you're caring for. You may say, well, I'm not grateful about anything. They're a real big problem. I'm really not grateful. Well, you might be grateful that they're still alive. You might be grateful that they have a nice smile or some sense of humor still. Perhaps they're a person who's persevered and still perseveres despite all their infirmities. So it takes a little practice, but looking closely at the person you're taking care of and trying to see, what can I be grateful for about that person? And let your mind reflect on that. And the third component is kindness. These are deliberate acts of kindness. And why do we do these? Because, well, biologically, there's this hormone called oxytocin, which calms our nervous system and reduces stress. And believe it or not, and this is true, higher levels of oxytocin are linked to gratitude and linked to trust, generosity, and gratitude, and reduction in shame and guilt. So therefore, resilience will be increased, right? So you might say, well, this is very trivial. No, it isn't. There's been several studies about the importance of consciously or deliberately doing acts of kindness. Not that it just happens, but you choose. It can be acts of kindness for yourself. Being kind to yourself is part of, obviously, what I've been talking about. But being kind, deliberately kind to your loved one when they do something that frustrates you, instead of becoming irritated or short-tempered or whatever else, you reverse it, you flip it, you do the opposite of what you think or feel, and you treat them with kindness rather than irritation. Makes a world of difference to your stress level and to theirs. Now, one of the studies involved writing a journal, and then writing how the individual felt after they did these acts of kindness. And what they discovered from that study was people who performed 5 acts of kindness, more or less every day of the week, okay, saw a significant increase in their happiness. You might say, well, oh my gosh, that sounds like a lot. And it is a lot to start with. So, just start with one or two, but you can build it up. And you'd be surprised at how it's going to make you feel, which again, in turn, is going to increase that sense of resilience. The next slide, I'm going to skip. So let's go to so this one. So yeah, before we go to that one, go back to the blank. Yep. So this is blank to remind me that I'm going to ask you now, how does this apply to you? What do you think about resilience? Do you think resilience is something you can cultivate? Would you be willing to try the 3 elements that I said are foundational? I'd like to hear from people how this is resonating with you. Are you feeling like resilience is something that is within your purview and you're going to increase it and you're going to try some of these things?
Hi, this is Lori. I was the one that had
Oh, hi, Lori.
Yeah, I'm sorry I couldn't get on. I couldn't figure things out. It's been a long time since I've done Zoom on my phone. Anyway, but I really, really like the idea of sort of switching up the knee-jerk anger response to the opposite, to one of kindness. I really, really like that idea because I think that what happens with caregiving, and I'm more of a professional caregiver, I feel that it's so easy to get so spent. And it's very, very, I think that to me would be one of the harder things to do, because you sort of want to respond knee jerk when you're angry,
Yes.
and to stop, and to be able to stop and to learn how to stop, and then sort of start turning it, even just with the way you speak, the tone of your voice. That is something that I would like very much to learn.
Yes, well,
Okay.
thank you very much, because that's a perfect segue into one of the handouts. So that's the other reason the screen is blank, because I want to call your attention to the handouts. Okay, which you may or may not have. If you don't have them, please let the organizers know and they'll be sure you get them. But we have a technique in here called the REST, R-E-S-T technique. Okay, and I'll just say briefly, where when you're in an upsetting situation and you're trying to think of some of these positive strategies to use, the first thing that you need to do is relax, which means take a breath, take a few breaths. If you can take 3 or 4 breaths, deep breaths, that's a good way to begin. Then you can evaluate the situation. What's really going on? Set an intention. How do I want this to turn out? If something's happening that my knee-jerk reaction is frustration, well, do I want it to turn out that it's going to be stressful for everybody? It's going to be an argument. There's going to be maybe some yelling, maybe some door slamming. Is that how I want it to turn out? Well, probably not. So you're thinking ahead. How do I really want this to get resolved? And then you take some action. So you relax through breathing, you evaluate. The S, you set an intention, and the T is you take action. And the handout has several pages describing this, so you can do it yourself. We don't have time to do it tonight together, but you can do it yourself. And that is a good way to help you with this reframing that we're talking about. All right, next slide, please. Okay, so a lot of times caregivers say, well, I don't have time to do any of this stuff that has to do with self-care. It's too complicated. I just don't have time. I'm busy, especially again, the middle-aged children, those who are still employed, regardless of age, who are dealing with someone living with someone with Alzheimer's or another form of dementia. They are busy. they are busy. But what research has shown is that micro breaks are good. Micro breaks will help reduce our stress physiologically and psychologically. So what is a micro break? What is, anybody want to say? What do you think is a micro break? How long's a micro break? An hour? No,
5 minutes?
5 minutes. Yeah, exactly. Now, there's nobody so busy that they don't have 5 minutes that they can spend on themselves, right? So, and maybe you have 4 minutes, okay? But, you get the idea. So the first thing that we recommend that you do when you take this little break is breathe. And I've deliberately spelled it out that way, nice and slow. Breathe, because it gives the concept that you're breathing slowly. You're inhaling slowly, not your normal breath. Obviously, we breathe all day long, right? And we breathe automatically. Mindful breathing, this breathing that I'm talking about for the micro break, is not the automatic, it's what we consciously do. So we decide we're going to inhale nice and slow through our nose. We're going to maybe pause a second or so at the top, and then we're going to exhale nice and slow. Many people exhale through their mouth. It's up to you. I like nose for the inhale. So let's just try it. Okay, you're all carrying stress with you, so I imagine you could use a micro break. So let's just try it. So we're going to inhale slowly through our nose. Pause. And then exhale. Let's do it again. Inhale. Pause. Exhale. And let's do one more. Everybody try it with me, please. Inhale. Pause. Exhale. Now that should be a tiny bit refreshing. I hope it is. It's a simple thing to do. The longer you do it, if you could do 5 or 10 breaths, so you've got a few minutes, the more you'll feel the physiological relaxation. Another thing that people like to do is move their arms, stand up, like if you're computer type or you sit a lot, standing up every hour, setting your watch or some other timer so you can actually get up and move a few moments each hour. Another thing that people do sometimes is grab a cup, take time out for a cup of tea or a cup of coffee. So you pour it and you don't just go right back to what you were doing, but you take time out to savor the moment. You might listen to music. We probably all have headphones. Stick them on. Turn on something you like. Listen to it a few minutes. You don't have to listen for 3 hours. A few minutes, a micro break. Is something that will help bring the stress level down. It's part of learning these skills to increase resilience. So we gave you the 3 building blocks, and now I'm telling you some other things to increase your sense of resilience or coping, being able to manage. The next slide, I talked about this already, savoring the moment. So let's go to the next slide because John brought this up earlier. More resilience boosters. I think, John, you brought up exercise, the yoga, right? Yeah. So several of these things we've talked about: acceptance, adjusting to the new normal. So that's cognitive. Humor, being able to find something humorous in a tough situation. You may not be able to do that with all the tough situations, but with some you can. Activity. That is so important. Again, there's a lot of current research that activity, moving, being active. It doesn't matter what you do so much as that you do it, and you do it for roughly 30 minutes a day. And that can be in short bursts. Again, you don't have to do 30 minutes, or you set the timer and you say, oh God, I gotta go out. Oh my God, I don't have 30 minutes. No, but you have time maybe to walk out to the mailbox. You have time to walk around in your backyard. You might be doing household chores, pushing the vacuum cleaner, whatever. That's activity. Maybe you turn on a YouTube and you dance with some Zumba class or something like that, or you do the yoga. It's what you like. The idea is find something you like, right? And then do it and change it up if you can, so that your goal is every day to get about 30 minutes of activity. And then last one is so important, and caregivers just don't do it often enough, is give yourself a pat on the back. You know, reward yourself, thank you, appreciate yourself, appreciate what you're doing. Take a moment to appreciate yourself. So these are all important components of building that sense of resilience, buffering you against future stress, as well as helping you manage the current stress better. Now, the next slide gives some of the key organizations: the Alzheimer's Association, AARP Caregiving, Family Caregiver Alliance, Institute on Aging, and then the VA Caregiver Support Program. These are, as I said earlier, I believe these are vetted websites. You can trust the information. They're all free, and they'll tell you a lot more than what I'm able to cover tonight. The next slide, the 36-hour day, that book's been around a long time. I think it's in, I don't know, the 10th edition or something. It's really kind of the basic book, if you haven't read it. If you're a caregiver of someone living with Alzheimer's or some other form of dementia, that's your book that you'll probably want to start with. And I also wrote about ADIR. This is another source of information that's sponsored by the National Institute on Aging. They have different things than what some of the others do. So if you search these different websites, I'm sure you'll get answers to some of your specific questions. And much of the ADIR material, as well as some of the other organizations, are in multiple languages. So if you have friends or relatives where English is not the first language, you can probably get those resources as well from these sites that I mentioned. The next slide, the next two slides are about mobile apps. Okay, so I think mobile apps are really important because we all use our phone, right? Where would we be? I don't think there's anybody in this group who doesn't use their phone every day and frequently and relies on the phone for information. Well, you may as well download one of the apps that will be helpful to you. So there are a couple that are specific for dementia caregiving, the first two, and then the next two are general. And you probably know some more. If any of you do have one you want to recommend, please put it in the chat, because these are key ones that I recommend to clients that I see, but there may be others that you have some experience with. So let's take a deep breath, because we're getting towards the end and I have one more topic I need to cover. So let's take a breath. Oh yeah, this one, the last one, walkthrough of how to use the mindfulness coach. Very helpful. Mindfulness, I didn't add it into the slides specifically, but I've certainly been talking about it. And this is a very good, easy to use coach for how to develop more mindfulness in yourself. The next slide. This one has to do with, okay, I've tried all of that. I'm still depressed. I'm still very anxious about the future. I'm miserable. I don't sleep. I'm not happy. My quality of life is down. Okay, you've tried these things. You've done the self-care. You've done the self-help. You've gotten the information. You've built your network. You've learned some coping skills. but you're still suffering. Well, in that case, you need professional help. And there's different kinds of help that can be useful. The one that I'm going to recommend, because it's the one that I'm trained most effectively in, is called cognitive behavior therapy. That's not to say the others are not as important and as useful, just to say that that's the one I prefer, because that's the one I've been trained in, and that's the one I know how to do pretty well. So in cognitive behavior therapy, you learn ways way beyond what I've talked about, how to manage your own depression and anxiety and stress. In all of these, you will to some degree or another. So the next question that often comes to mind in the next slide, how do I find such a person? Yeah, well, it ain't easy in this world of, insurance being cut and services being cut and difficulty with access to care. It's not easy to find a mental health provider who knows something about caregiving and whom you're able to afford, where you can work out the logistics and so forth. These, again, are trusted sources that I feel comfortable recommending to you. So the OATS program is located at El Camino Hospital in Mountain View. They have, the individual goes there 2 days a week for group therapy. So they have group therapy, they have individual therapy, and they also have a psychiatrist on staff who helps with medication management if that's necessary. It is covered by Medicare. It is a not often enough used resource. Part of it is because you do have to go there. You have to go to Mountain View. So depending where you live, that might be an obstacle. But if that's not an obstacle, it's a really outstanding program. Blue Moon Counseling is one that we refer people to from Stanford when we have a wait list. And because, again, we trust them. The same with Be Well and the Mental Health LLC. Now, the Stanford outpatient, we have a geropsychiatry clinic. Barbara ran the clinic for years. She is still a consultant. I'm a consultant to the clinic. We have groups, we have individual therapy, different approaches depending upon the nature of the problem. So these are sources you might consider. And then Meru is one that delivers the therapy through a mobile app with some interaction with the therapist. So for some people who, can't drive, don't want to drive, don't have the time, can't work out the insurance, whatever, this is an option. So next slide, which will be the last, which are the conclusions, okay? And then it's 8:27. So there are many options, right? Depending, I showed you the stepped approach, a way to think about what your needs are. And then I've been sharing resources with you. There are more resources in the resource list. Why should you bother? Because if you don't, you're going to go to burnout, and that's not going to be good for anybody. You will have increased quality of your life because you matter too. The caregiver matters. And if you don't take care of yourself and you go down, who's going to take care of your loved one? Most of us don't have a very good emergency plan, you might say, something to keep in mind. But yeah, and there's resources are highlights and not all inclusive. Again, some of you might be aware of other resources that you've come across. If you want to put them in the chat and share them, that would be great. If not, please print out or refer back to this slide set, refer back to the handouts, and please make use of the materials that we provided. And we've got a few minutes left. I'm happy to stay on longer. I don't know about all of you. You might be tired, and we've come just about to the end of our time, but I'm here for any further discussion, and I'm happy to stay on longer if there's more discussion. So
I have a quick question.
Yeah.
So, my husband, had an appointment with a neurologist, I don't know, last year. Anyway, the test was pretty perfunctory. My husband happens to be a very, I want to say, brilliant with numbers, and so you can tell him to count backward from 100, give him
Oh.
any number, and he's there. I could see that the neurologist was impressed, and he passed with flying colors. So we asked Sutter Health, or we tried to get a second opinion from another neurologist, and that was denied. So we, both of us, really think further assessment would be helpful. Do you have any suggestions where we could uh, get an assessment? And the reason I'm so interested is that I understand there is a treatment for early stage dementia, that if you go too far into the disease, then it doesn't help. So we need a diagnosis.
I understand. Barbara, you want to?
Yeah, it's so interesting because, a fall off from cognition means a fall off from a previous level. So if you start off being extraordinarily smart and now you're only smart, it still means it's a fall off, even though you're smart. And some of these really rudimentary tests don't cover it. There is a memory center at UCSF, and I know I'm, advocating for the enemy here, but they have a really superb department, and they do nuanced testing, and they also have a lot of investigational medications. The neurology clinic at Stanford tends to not want to diagnose dementia until it's very, very clear. And I think some of the reason they do that is for criteria to be met for their research projects. They can't be nuanced. We do memory testing at our clinic, but if insurance doesn't cost, it'll cost a lot of money, like upwards of $1,000. So that's why I'm thinking UCSF may be a good choice.
There's also the Stanford Alzheimer's Disease Research Center, so I'm putting that in the chat. They offer diagnostic testing and also biomarkers. They do all of that, and they have a lot of clinical trials where you might be able to get some of this medication. So I can't remember the website offhand. I'd have to look it up, but I will if you want me to.
No, that's all right. I'm sure I can find it. I
Yeah.
appreciate both inputs. Thank you.
Yeah, you're welcome. So other people, there's some we haven't really heard. Oh, Lori had a question. I don't know if anybody saw it, which is the person a veteran? Because if they're a veteran, then they're eligible for VA, which has quite an extensive program as well. So is your husband a veteran?
You're muted, Miriam.
No, he's not. We have both Medicare and AARP supplement. So our insurance is pretty good.
Yeah.
Yeah.
But it wasn't an insurance thing that Sutter Health denied a second opinion. It was that he did so well, apparently.
Yeah. Well, as Dr. Sommer mentioned, there are many more sophisticated tests than what he had. He had a very basic one that is often used in primary care and so forth, but not sophisticated. Yeah,
It's the reason I actually memorized that test.
You memorized it, Barbara? Oh, that's funny.
But then, Barbara, then you won't qualify for the early intervention medication,
There you
right?
go. But I won't have the diagnosis. You're not sick if you don't have the diagnosis.
Yeah, and it's controversial whether the early intervention medication does a lot, you know.
Yeah, in fact, I don't know what Michael Gracious's stance is on that right now. He's the neurology person, but when they first came out, Stanford was not doing the monoclonal antibodies because the risks were considered too severe for the potential gain.
Yeah, I'm not sure what the situation is now.
Yeah, some of the newer ones are actually less deleterious than the first ones, so I haven't been keeping up with that.
So again, if you go to the Alzheimer's website, you'll get there'll be information about what some of these newer ones are and what they can do.
Thank you both.
Mhm. So any of the people we haven't heard from, Sharon, it looks like you
Yeah.
went off mute. Yeah. Mhm.
Hi. So sorry to join late. I actually flew across the country on a red eye last night, and I'm working on 2 hours sleep to visit my 97-year-old mother who does have dementia. So I'm not a caregiver in any sense of being with her all the time, but California to Florida, my sister and I spend tremendous amount of time and energy worrying about her and trying to organize her life. So I was just distracted with doing dinner and whatever and forgot that this program was starting 10:30, I guess 10 o'clock my time. So I missed, is there a way to see the recording? Is there a way to see the slides? Is there a way to hook into the resources that you had listed that I missed?
Yes, my understanding is that the PowerPoint will be sent to you. Also, Sharon, you signed up already, so through the synagogue's office. So there's a resource list as well as handouts with some more in-depth information than Dr. Gallagher Thompson was able to present this evening.
Okay.
I have a question for the group, and I'm wondering, I know that we've only had like an hour and a half together, but I know that the synagogue and that Nat and that this committee of people who one of the first things to do was to bring Dr. Gallagher Thompson in to talk to you, wondering if you're interested in getting more resources. Are you interested in gathering to support each other? What can we as a committee do to support you in your journey with your loved one? Because we are certainly open to helping out in whatever way that we can. So I don't know if people want to, I'm Susan Rose Mail at yahoo.com if you wanted to send me your ideas or put them in the chat. But this is just one of things that we could do. We want to be there for you. We are a community and we want to support everyone in their caregiving journey.
I mean, speaking for myself, I would be interested in pursuing this further. But as I said, I'm not maybe in the same situation as everyone else, but certainly spend a tremendous amount of time worrying about my mother and trying to figure out ways to facilitate having her life be as good as it can be when we're thousands of miles away.
Are other people feeling similarly? Perhaps you already have a support system, or just wondering if you'd like to have the chance to chat informally and share experiences and resources. So just we're here, Hanani, and we want to help. So let us know what we can do.
Susan, I feel like I've already talked enough, but I would be interested.
Okay. So perhaps if it's okay with everyone, we'll follow up with an email. We had 21 people sign up for the group. Another several joined us, but there were some people who weren't able to make it this evening. And so perhaps if it's okay with you, we'll follow up with an email to find out what else we can do to be supportive, what areas you're interested in and perhaps what the next steps might be, if that's okay with everyone.
Yeah, you got a lot of head nods, yeah.
Okay.
Before we sign off, I just wanted to ask people to take a look in the chat if you haven't looked at it in the last few minutes, because there's quite a few resources that have been mentioned. So John, do you want to come off mute and talk about yours, because not everybody might have the ability to check the chat.
So I was fortunate in a way to have patients with dementia when I worked at the VA, and one who had pretty significant impairment from Alzheimer's disease on top of a pre-existing stroke. And that was when this new protocol for treating Alzheimer's disease was first published. And I thought, well, why not give it a try? It involves 20 minutes a day of exercise in one block, a very specific diet that's based on labs, not just your kind of generic healthy diet, and then learning a new skill, something you've never done before. And gosh, there was a fourth one. Blanking what
Supplements.
Say again?
Supplements.
Well, that could be part of the diet. Anyway, so it takes a lot of caregiver support to get someone with dementia to do these things, because I talk to them and they agree, and then I talk to them the next day and they don't remember any of it. And why should I do this stuff? I'm fine. But if people do it, they can actually reverse most or all of their symptoms. And there's great published data on people who had very demanding jobs, accountants, lawyers, who had to stop work because of their dementia and then were able to return fully functional from doing these things. It doesn't seem to work on other forms of dementia or other causes of dementia. It really seems specific to Alzheimer's. So it's important to have an accurate diagnosis prior to putting all this effort into it. There are trained coaches available that can be found online to help the caregiver with this, or reading Bredesen's papers that can be downloaded online. It's really possible to figure out how to do this on your own. Although you will need to see a nutritionist or a geriatrician to get the labs and help you devise the special diet.
It's really
sleep, that was
not
the
for the
fourth one.
faint of heart. It's very labor intensive. It requires an enormous dedication to the project. And in my view, having the motivation to do it already speaks to a better prognosis, because it's a self-selected group. The people who just think, oh, darn, I can't do this, may have a different prognosis than ones that are willing to do it. But it requires an obsession with diet and supplements and exercise. But if you do it, the data is pretty impressive. But you do have to make that your new vocation. And that's all I'll say. I mean, frankly, I don't think I could do it.
I think also you have to continue with the protocols. It's not that
Yeah,
you can
I
do
mean,
it
yeah,
for
you're
3
marrying
months
this
and then you're
thing.
better. And
Yeah.
then
No,
because
you're
if you
married to this thing,
right,
and
right.
it
Everything's
really
a
is your
lifestyle.
it's your new profession. And if you've got the motivation and the ability and the finances to do it, cool. Frankly, I don't think I have it myself.
In terms of finances, though, it's quite low cost.
Is it?
Yes, you're for the most part, it doesn't require any prescriptions. All the supplements and food is available at the grocery store. And exercise doesn't have to cost anything. Changing your environment to get better sleep doesn't have to cost anything. But it is very labor intensive. So that's something to remember. And as Susan said, you have to keep doing it. So you can get better. And then if you quit doing these things, your symptoms come back.
Yeah, but I think it's wonderful program in the sense that it shows that lifestyle changes, not medication, making lifestyle changes, intensive ones, intensively, and then sticking with it. Because after all, dementia is progressive, right? Alzheimer's is progressive. So you can't just do something for 6 months and then say, okay, I'm cured, there is no cure. This is not going to cure it. But what it is going to do is keep the person, well, it can reverse a lot of the symptoms, and it can keep the person healthy for as long as possible, as long as they stay with the program, is my understanding. So I think it's a great alternative if you, for whatever reason, can't or don't want to take the available medications. So thank you all. We're at about 8:45, and I really appreciate everyone's attendance and your participation. You have my email if something comes up or you have a question from the talk tonight, send me a message. I'll be glad to respond. And good luck in your journey.
Thank
Yeah.
you so much, Dolores. This was really fabulous. And as you can see by the questions, very promoting of further conversation. So thank you.
And thank you to everyone who participated.
Yes.
You're on my list and you'll hear from me. So let us know what we can do to help out.
All right.
Thank you.
Thanks again, Dolores.
Thanks,
Good
Jake.
night.
Thank you.
Good night, everyone.
Good
Thank you,
night.
Jake.
Thanks,
Yeah,
Jake.
thank you, Jake. Yeah, the unseen Jake.
Bye,
Unseen,
everyone.
but very important. Okay.
Bye.
Bye-bye.
Bye.